The dural venous sinuses are where the venous blood runs, and also where CSF is resorbed. The detailed anatomy is not that high yield for the exam. You should recognize that all the sinuses eventually drain into the internal jugular vein. CSF is absorbed into the arachnoid granulations. The most important sinus is the cavernous sinus because of the important structures that run through it. Cranial nerves 3, 4, V1, V2, and 6. Cavernous sinus thrombosis can lead to headache and also cranial nerve deficits. Sagittal sinus thrombosis is caused by hypercoagulable disorders, especially in pregnant women. These patients may present with seizures, headaches, or strokes. The ventricular system is where the CSF is made and flows. The CSF is made by the choroid plexus cells lining the lateral ventricles, and it is resorbed through the arachnoid granulations into the venous sinus system, as we just mentioned. Now, there is one lateral ventricle in each hemisphere that drains to the midline third ventricle and fourth ventricle. What is the path by which the lateral ventricle drains into the third ventricle? The foramen of Monro. And what is the path by which the third ventricle drains into the fourth ventricle? Right, the cerebral aqueduct. Now, the fourth ventricle has 3 outflow tracts, the paired foramina of Luschka, L for lateral, and the foramen of Magendie, M for medial. Hydrocephalus is known as water in the head, and it is caused by increased CSF in the intracranial cavity, leading to mass effect. NPH, or normal pressure hydrocephalus, is commonly seen in the elderly. The ventricles are abnormally dilated, but the CSF pressure is not elevated, hence the name. This is thought to be due to impaired CSF reabsorption at the arachnoid granulations. Patients present with the classic triad of symptoms: urinary incontinence, dementia, and gait ataxia, which you may remember as wet, wobbly, and wacky. It's important to diagnose, as it is a reversible cause of dementia in the elderly. Communicating hydrocephalus is caused by impaired CSF absorption or excessive CSF production. There is no obstruction within the ventricular system itself, hence everything communicates. Non-communicating hydrocephalus, or obstructive hydrocephalus, is caused by some sort of true obstruction of flow within the CSF system. One common place for the obstruction is at the aqueduct of Sylvius. What are the symptoms that patients may complain of? The symptoms of hydrocephalus include headache, nausea, vomiting, cognitive decline, altered mental status, papilledema, as well as cranial nerve 6 palsy. Patients may also have a magnetic gait, where the feet shuffle along the floor. Now, hydrocephalus ex vacuo occurs in areas of previous brain damage. Essentially, the damaged brain tissue is resorbed and the space filled in with CSF. It's not symptomatic, but will appear on imaging as a hole in the brain. There are 31 spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Where along the spine do the spinal nerves exit? Well, C1 to C7 exit above the corresponding vertebra, while the remainder exit below. A slip disc will cause paresthesias and motor deficits along the area of distribution of nerve. Vertebral disc herniation most commonly occurs between L5 and S1. In adults, the spinal cord ends around L1 to L2. Therefore, a lumbar puncture is generally performed between L3 and L5 to prevent harming the spinal cord. Remember, to keep the cord alive, keep the needle between L3 and L5. We're going to cover spinal tract anatomy and functions as we review these tracts. There's 1 motor tract and 2 sensory tracts that you need to know. The motor tract is called the lateral corticospinal tract and mediates voluntary movement of the arms and legs. The dorsal column medial lemniscus is one of the 2 sensory pathways. It mediates pressure, vibration, touch, and proprioception. The spinothalamic tract mediates pain and temperature. Note that the legs are lateral in the lateral corticospinal tract and the spinothalamic tract, but they're actually medial in the dorsal column. Now we'll dive into some more detail about these tracts. The dorsal column medial lemniscus, which we mentioned deals with touch and vibration, has primary sensory neurons located in the dorsal root ganglion. The neuron travels ipsilaterally up to the medulla, where it synapses in the nucleus cuneatus for the upper body and in the nucleus gracilis for pathways from the lower body. The second neuron then crosses to the contralateral side as it travels up the brainstem to the thalamus, where it synapses with a third neuron traveling to primary somatosensory cortex. The spinothalamic tract has cell bodies of the sensory neurons located in the dorsal root ganglion. Unlike the dorsal column, which ascends ipsilaterally, the spinothalamic tract synapses immediately upon entering the spinal cord through the dorsal root. The second neuron then crosses through the anterior commissure to the contralateral side and ascends to the thalamus, where it synapses again. The third neuron then travels from the thalamus to the primary somatosensory cortex. The last of the three major tracts is the lateral corticospinal tract, which is the descending motor tract. The neurons originate in primary motor cortex, decussate or cross at the medullary pyramids, and descend down the spinal cord. The upper motor neurons synapse in the ventral horn of the spinal cord, and the lower motor neurons exit through the ventral root to innervate muscles. Each cerebral hemisphere controls the contralateral body because of the pyramidal decussation. Later we'll look at a hemilesion in the spinal cord to review the function of each of these tracts.